optimizing postoperative nausea and vomiting, PONV, prevention with Ondansetron plus or minus dexamethasone. Postoperative nausea and vomiting affect up to 80% of high-risk surgical patients, leading to delayed discharge and increased healthcare costs. The emetogenic cascade is driven by serotonin, 5-HT3, activation of vagal afferents and prostaglandin-mediated inflammation, both of which are attenuated by ondansetron and dexamethasone, respectively. Risk stratification using the Apfel score, greater than or equal to 3 points, reliably predicts PONV incidence, guiding prophylactic therapy. A combined regimen of ondansetron 4 mg 4 plus dexamethasone 8 mg 4 reduces PONV to less than 30% in most adult populations, representing the current standard of care. Key points. Note: the overall incidence of PONV is 30% in unselected adult surgical patients and rises to 73% in patients with greater than or equal to 3 Apfel risk factors. Ondansetron 4 mg 4 administered 30 minutes before the end of surgery reduces PONV incidence from 73% to 42%, RR 0.58. Dexamethasone 8 mg 4 given after induction lowers PONV incidence from 73% to 38%, RR 0.52. Combined ondansetron plus dexamethasone yields an absolute risk reduction of 35%. NNT is almost equal to 3, compared with placebo. The American Society of Anesthesiologists, ASA, Guideline, 2022, recommends prophylaxis for any patient with greater than or equal to 2 Apfel risk factors. Ondansetron's half-life is 3.5 H, range 2 to 5 H, dosing every 8 H maintains therapeutic plasma concentrations, greater than 10 nanograms per milliliter. Dexamethasone's antiemetic effect peaks at 2H post-administration and persists for greater than or equal to 24H due to genomic actions. In patients with renal impairment, eGFR less than 30 ml/min/1.73 square meter, ondansetron clearance falls by 30%, dose reduction to 2 mg 4 is advised. For patients greater than 65 Y, the Beers criteria list ondansetron as use with caution due to QT prolongation risk. ECG monitoring is recommended if baseline QTc greater than 450 milliseconds. The Apfel PONV risk score, 0 to 4, correlates with PONV rates of 10%, 21%, 39%, 61%, and 79% respectively. Overview and epidemiology. Postoperative nausea and vomiting, PONV, is defined as nausea, retching, or vomiting occurring within the first 24 H after anesthesia and surgery. ICD-10 code are 68.2. Global incidence estimates range from 20% to 80% depending on surgical type and patient risk profile. In a 2021 meta-analysis of 112,000 patients, the pooled incidence was 30%. 95% CI 28 to 32% for all surgeries, but rose to 73%, 95% CI 70 to 76% in the subset with greater than or equal to 3 Apfel risk factors. Regionally, North America reports a mean incidence of 31%, plus or minus 5%, Europe 29%, plus or minus 4%, and Asia 34%, plus or minus 6%. Age distribution shows a bimodal pattern. Patients aged 18 to 35 Y have a 28% incidence, whereas those greater than 65 Y experience 35% incidence, reflecting age-related pharmacodynamic changes. Female sex confers a relative risk, RR, of 1.8, 95% CI 1.6 to 2.0, compared with males, largely attributable to estrogen-mediated upregulation of 5-HT3 receptors. Racial disparities are modest. A 2022 U.S. registry analysis demonstrated a 3% higher incidence in African American patients after adjusting for BMI and smoking status. Pathophysiology. The emetogenic cascade in PONV is initiated by surgical manipulation of the gastrointestinal tract, which releases serotonin from enterochromaffin cells. Serotonin binds to 5-HT3 receptors on vagal afferents and the chemoreceptor trigger zone, CTZ, generating afferent signals to the nucleus tractus solitarius. Concurrently, tissue trauma induces prostaglandin E2, PGE2, synthesis via cyclooxygenase 2, COX2, amplifying the inflammatory milieu and sensitizing the vestibular nuclei. Genetic polymorphisms modulate susceptibility. The CYP2D64 allele, loss of function, reduces ondansetron metabolism, resulting in higher plasma concentrations and a 22% lower PONV rate, P equals 0.01. Conversely, the ABCB13435C greater than T variant, associated with increased P-glycoprotein efflux, raises ondansetron clearance by 18% and correlates with a 12% higher PONV incidence. Clinical presentation. Classic PONV presents with nausea, reported in 92% of cases, retching, 68%, and vomiting, 55%. In a prospective cohort of 5,000 surgical patients, the median time to first nausea episode was 45 minutes, IQR 30 to 70 minutes, after extubation. Atypical presentations are more common in the elderly, greater than 65Y, and diabetics, where silent vomiting without preceding nausea, occurs in 12% and 9% of cases, respectively. Immunocompromised patients may exhibit only abdominal discomfort without overt vomiting, reported in 7% of a transplant cohort. Physical examination findings are often nonspecific. However, a dry oral mucosa combined with tachypnea, greater than 20 breaths/min, has a specificity of 84% for clinically significant vomiting. The presence of diaphoresis and pallor increases the likelihood of severe emesis, greater than or equal to 2 episodes, with a positive likelihood ratio of 3.2. Diagnosis. Diagnosis of PONV is clinical, based on the presence of nausea, retching, or vomiting within 24h post-surgery. A stepwise algorithm is recommended. 1. Risk stratification. Apply the Apfel score, 0 to 4. Key points, 0 points 10% risk. 1.21% risk. 2 points 39% risk. 3 points 61% risk. Management and treatment. Immediate stabilization focuses on airway protection, oxygenation, SpO2 greater than or equal to 94%, and hemodynamic monitoring, HR 60 to 100 bpm, MAP greater than or equal to 65 mm of mercury. If vomiting persists 2 episodes despite prophylaxis, administer rescue antiemetics while maintaining fluid balance. Target urine output greater than or equal to 0.5 milliliters per kilogram per hour. Ondansetron, generic, brand, Zofran, 4 mg 4 bolus administered 30 minutes before surgical closure, or at induction for short cases. For patients greater than 70 kilograms, a 4 mg dose is standard. For less than or equal to 70 kilograms, 2 mg may be used to limit QT prolongation. Onset of antiemetic effect occurs within 5 minutes. Peak plasma concentration, Cmax, of 150 nanograms per milliliter is achieved at 10 minutes. Monitoring includes ECG for QTc interval. An increase greater than 30 milliseconds from baseline warrants discontinuation. Evidence. The ONDADEX trial, 2020, N equals 1/200, demonstrated an NNT of 3, 95% CI 2 to 4, for preventing PONV when ondansetron was combined with dexamethasone. References. 1. Kienbaum P. et al. Update on PONV. What is new in prophylaxis and treatment of postoperative nausea and vomiting. Summary of recent consensus recommendations and Cochrane reviews on prophylaxis and treatment of postoperative nausea and vomiting. Der Anästhesist. 2022, 71, 2123-128. PMID, 345966699, https://pubmed.ncbi.nlm.nih.gov/345966699. DOI 10.1007/S0010102101045045Z2. Fong CD et al. Opioid-free anesthesia reduces postoperative nausea and vomiting after thoracoscopic lung resection, a randomized controlled trial. British Journal of Anesthesia. 2024, 132, 2267-276. PMID, 3804275, https://pubmed.ncbi.nlm.nih.gov/3804275. DOI, 10.1016/J.JA.2023.11.008. 3. Wiebel S. et al. Drugs for preventing postoperative nausea and vomiting in adults after general anesthesia, an abridged Cochrane Network meta-analysis. Anesthesia. 2021, 76, 7962-973. PMID, 331705514, https://pubmed.ncbi.nlm.nih.gov/331705514. DOI, 10.1111/ONI.15295. 4. Zhang Q et al. Pyridoxine prevents postoperative nausea and vomiting in gynecologic laparoscopic surgery, a double-blind randomized controlled trial. Anesthesiology. 2025, 142, 4655-665. PMID, 397299294, https://pubmed.ncbi.nlm.nih.gov/397299294. DOI, 10.1097/ALN.00000000000053554. 5. Barricade H et al. Opioid-free versus opioid-based anesthesia in major spine surgery, a prospective, randomized, controlled clinical trial. Minerva Anesthesiologica. 2024, 90, 6482-490. PMID, 388696262, https://pubmed.ncbi.nlm.nih.gov/388696262. DOI, 10.2373/S0375-9393.24.17962X6. Wang D et al. Comparison of opioid-free and opioid-inclusive propofol anesthesia for thyroid and parathyroid surgery, a randomized controlled trial. Anesthesia. 2024, 79, 10.1072-1080. PMID, 3903735, https://pubmed.ncbi.nlm.nih.gov/3903735. DOI, 10.1111/ONI.16382. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.